balancing of the hip. Over to you, Prof.
Thank you, Abhay. Welcome to all of those joining us live, and more so to those that will join us in the next week or two, as we'll be posting the recording of this session on our website at apasonline.org.
Recording in progress.
APAS has been going for some time now, and as some of you and many may be aware, we have annual scientific meetings. The last one was very successful. The next one will be in Kuala Lumpur in Malaysia in August next year. But at our President David's insistence, we are now extending beyond the annual scientific meeting to hold webinars so we can have scientific material delivered to you on a more regular basis, and I think that's an excellent idea. We've had conjoint webinars with IOA in the past, but this is really the first where we stand APAS solo, and I would like to thank Abhay for his organisational skills in pulling this together, putting together an excellent program for this afternoon. And drawing in the faculty to all well-seasoned APAS faculty and executives who will be joining and sharing with us their information for this session. So make sure you join us after the session on the APAS website for further queries, inquiries, and a review of the material that's delivered. So I've been asked to deliver a topic on 3D balancing in hip replacements. It's about a 10-minute presentation I'll share with you, after which there'll be some questions then following on with the rest of the program. Just give it time to set up. Okay. And just minimize that. Excellent. All right, so the topic for discussion is three-dimensional balancing in total hip replacement, techniques, evidence, and outcomes, and sharing with you the concept of what this is about. So to introduce it, three-dimensional balancing optimizes hip biomechanics in all three planes. It goes beyond the static alignment to include dynamic spinopelvic motion, and the goal of this is a stable, impingement-free hip movement with accurate leg length and offset. Templating, as seen here, is really historical. This is what we've done for decades. I know some of you may still do it. I haven't put up a template to an X-ray for about 4 years now, and sharing with you the whys and wheres and how fors. So it's not uncommon to see this still done, and it can still deliver good results as it has over the decades. But in 2025, we've moved on a little bit. Why? Because the introduction of digital radiology has disturbed magnification. APAC's imaging systems and technology now make radiology films a lot more scarce, so it's harder to get a hold of. And even when you do get a hold of them, the magnification means that the current templates we're using may not be accurate. This is reflected here between old and new templating. You can see on the left-hand side here a standard templating with new radiology tells me that this should be a size 2 femoral component. In fact, what I end up putting in is a size 4 femoral component. And when I go back and template for a size 4, it looks too big on the current radiographs. And it's this discrepancy that can lead to errors, it can lead to fractures, and it can lead to problems with patient outcomes. So it's a historical context in that two-dimensional templating is limited to coronal plane landmarks, but now CT, robotics, and spinopelvic studies have shifted focus to three-dimensional function. And we're transitioning from what's traditionally known as safe zones. The Lewinec zone has to be mentioned every time we talk about safe zones, to what we should be using now, which is functional zones. Papers like this is actually from a colleague of mine in our department, Brahman Sivakumar. Interestingly, he's now a hand surgeon, but he published with Warwick Bruce, all from Australia, basically on prior lumbar-spinal fusion being associated with an increased risk of dislocation and revision total hip replacement. This was a meta-analysis. So patients with prior lumbar spine fusion are at significantly increased risk of dislocation and revision after hip replacement, and concluding that surgeons should pay particular attention to these patients and consider using patient-specific planning and instrumentation. This paper by Perilla in 2019 in Journal of Arthroplasty, retrospective radiographic analysis of 135 patients receiving hip and spine surgeries, and compared various spinopelvic parameters and dislocation rates, looking at the metrics of whether there's a significant difference if you do the hip first or the spine first, which sequence makes a difference. And when comparing patients who had dislocations with those that didn't, the dislocators had a lower lumbar lordosis, a lower sacral slope, a higher pelvic tilt, and a higher pelvic incidence, in keeping with a stuck sitting phenomenon that's consistent with changes attributed to spinal fusion. Dislocation in hip replacement with lumbar spine fusion or concurrent spine pathology is dependent on deviation of the spinopelvic parameters from normal values and acetabular cup position. So we should take this into consideration. And a lot of publications now have evolved over the last decade. This editorial 2 years ago, Journal of Arthroplasty, essentially the benefits of spinopelvic relationship optimization has been studied radiographically, and publications have increased from 2 in the literature in 2014 to over 100 in 2022 and continue to increase. Literature is demonstrating that spinopelvic biomechanics may influence hip stability following hip replacements, and that preoperative assessment of biomechanical relationship between spine and hip has now become a very important step in the evaluation. One paper you really should go to if you haven't had the opportunity is that by Jonathan Vigacek in 2023, work also done by Jim Piermont. And these guys have really evolved this science to a significant degree. And it's these parameters that I use as part of the software program I currently utilize for templating three-dimensionally for balance over the last 4 years. They looked at 48 recurrent hip dislocators, compared them to a control cohort of over 9,000 hips. That included lateral x-rays for pelvic tilt, lumbar lordosis, CT for pelvic incidence, cup orientation. And this is the protocol I use now in workup of a patient. They get x-rays of the pelvis, x-rays of the spine, both standing and flex-seated, as well as CT. And the at-risk spinopelvic parameters they identified is pelvic tilt less than -15 degrees, lumbar flexion due to stiffness less than 20 degrees, and sagittal spine deformity greater than 20 degrees. That's the difference between the pelvic incidence and the lumbar lordosis. A very good diagram that defines that very nicely. So if you can get a hold of this presentation and publication, you'll go a long way to understanding the concepts behind spinopelvic mechanics. And interestingly, they define that 71% of their dislocating group was within the safe zone. Therefore, the safe zone is no longer safe. We should be talking about functional zones, more individualized per patient for hip replacement. The significant risk factors is a pelvic tilt less than 15 degrees, lumbar flexion less than 20, and a PI-LL mismatch less than 20. This provides fourfold more prevalent risk of unstable hips. 11% of the control patients had one spinopelvic risk factor, but 67% of the dislocating patients had one or more of these risk factors, and this was significant. So the whole combined anteversion concept integrates acetabular and femoral inversion into one functional measure. The target range is typically between 35 and 45 degrees, and it's specific to approach, whether you're coming from behind in a posterior approach standard or a direct anterior approach. It improves range of motion, reduces the dislocation risk by minimizing the risk of impingement. So the core principles of 3D balancing: restore femoral offset, leg length, and a combined anteversion. Secondly, account for pelvic tilt and functional orientation. And finally, balance between the bony and soft tissue constraints at hand. There's a number of software programs that allow you to do this. Formus planning software for THA based on CT gives you orientation of your acetabular component and your femoral component and records a surgical plan at the end. The ZB1 planner allows the integration of spinopelvic dynamics. That's got to be input. At the moment, it's input by hand, but AI will take care of that as well. That's utilized in determining the pelvic incidence, sacral tilt, spinopelvic tilt, then incorporating that to determine where you should position your acetabular and femoral components to optimize offset. The delivery method can be also using technology, and here utilizing robotics, such as Rosa for hip planning, and then a combination of robotics for impaction and then fluoro to identify the position, make sure you can execute and deliver the position that's selected preoperatively, both for the acetabular and the femoral components, determining outcome. Why? Because robotics certainly continues to be increasing in terms of uptake over the past decade. That's because we're looking at precision and accuracy. We know the zones here, be it Lewinett or Kalnin. That's what generally you're aiming for, but aside from the fact that we're going now to functional zones, even if you are determining a particular zone, you're aiming for a particular position of inclination and eversion, if you use technology, you're going to narrow that position of where you're going to end up with improved accuracy and improved precision if you know your target zone. This is what I use, and I'd like to share it with you. This is the OPS system that I use for every patient involving plain x-rays of the pelvis, lumbar spine, from standing to flex-seated. The spinopelvic parameters are taken into account. If there's any red flags here, this is where I might utilize a dual mobility to decrease the risk of instability if I can't change those red flags. I look for impingement. I basically template in 3 dimensions, both on plain x-ray, heat map that tells me the integration, particularly with the cancellous and cortical bone, particularly useful in cementless technology, but also utilizing 3 dimensions with a CT to ensure I've got the correct fit of both the acetabular and femoral components. I look at the leg length discrepancy before surgery and with the planned implantation. I look at the offset change. I can see the stem version, both the natural version and the planned version of insertion of the femoral component. Once you've ruled out that there's no spinopelvic dynamics that you have to take into account, I can then look specifically at the size of the implants and their positioning. I'll just move this forward for the sake of time. You can see here, you can look for impingement of the prosthetic components, both in full extension and full flexion. And with the bony simulator, you can look to see if there's any bony impingement, particularly in full flexion, that can force you with posterior instability into a dislocation. These can determine whether osteophytes need to be removed, or you can modify the position of your acetabular component, lateralize it slightly to decrease the risk of bony impingement. 3-dimensional templating using the 3. You can see here where the position of the acetabular component needs to be, and that's what you've got to reposition at the time of surgery. You can go through the CT to make sure you've got good fit of the acetabular component, and similarly in both directions, good fit of the femoral component. You can look at the position of center of rotation, both in the coronal and sagittal plane, to ensure you're reproducing the position of center of rotation for the acetabular and femoral components. That goes a long way to optimizing balance in 3 dimensions. Once you've done that, you're ready to implant your prosthesis. Now, the delivery mechanisms can vary. Here I use patient-specific instrumentation, both for the femoral neck cut and also for positioning the acetabular component using laser technique. This is very effective in my hands, and I use it on a regular basis. Another means is to utilize technology such as a combination of fluoro, AI, and robotics, where you identify the position of the acetabular component, identify it on the fluoro, and using AI, it ensures that your position and target is secured, both for the acetabular component and for the femoral neck cut, and ultimately the femoral component. And therefore you can reproduce the combined anteversion you're looking for, positioning of your femoral component, so you make sure you don't end up with a leg length discrepancy as per the plan. I want to share a case example. This is the advantage of 3-dimensional planning and balancing, and it's a real good case to share with you. This is a 76-year-old female presented with pain and disability for 6 months, 50-meter walk capacity. You can see why she's struggling to walk there. And the real question here is, are we going to get away with primary implants, or are we going to need something more? We'll look at her spine. She's got some mild pathology that has to be taken into account. But the beauty of this is the engineers can get back to you before the planned surgery to let you know, hey, there may be a problem here. We can't make an acetabular component fit the defect that you have. Please review. Your clinical support can also reach out to you and let you know this is a case you need to pay more attention to, and therefore you can start your planning a week before surgery instead of 10 minutes before surgery. So I go through the plan, I optimize it. I can see here, do I need a TMAS system? Am I going to need an augment superiorly here? But I basically modify this. I increase this to a size 60 to see if I can get a fit. Can I fit a primary cup in here? And in fact, I can see that I can get a good rim fit. I'm happy to sacrifice some of the medial wall in order to achieve anterior to superior contact. I can see from the heat map, I've got 60% host bone contact. I can bone graft the residual cavitary defects superiorly and get away with this. So this is what we aim to deliver. We execute this using the technique. This is a cup going in. It's a cup with a high profile, 2 screws in place. I keep her on crutches for a period of 6 weeks. We bone graft medially. At 6 weeks, she comes to see me. She's finally off crutches at 6 weeks, able to take full weight on that left leg, and happy with the resolution of pain that she's had for 5 months prior to the surgery. And at 6 months, she's formed good bone in that medial wall. The cup remains stable. The femoral component remains stable. And at present, she's now very happy in terms of the outcome of a hip replacement. She's walking freely, and she's able to execute good balance on both left and right sides to the point where she's happy to demonstrate good mobility, good function, and good stability. That's what you want from a hip replacement in 2025, and three-dimensional balancing helps you achieve that. So in summary, three-dimensional balancing improves precision and understanding of total hip arthroplasty biomechanics. Functional planning enhances stability and reduces impingement, particularly. Evidence is promising, but ongoing for long-term benefits is required. In conclusion, modern hip replacement has become very sophisticated. Optimizing comfort step position to reduce and eliminate dislocation risk requires all three of the following: a modern system for templating cup and stem size and position, an individualized approach to cup and stem orientation based on the patient's spinopelvic parameters, and a reproducible and accurate delivery system to deliver the planned cup and step position for every patient. Thank you for your attention. Thank you, Abhay.
Thank you, Prof. That was a wonderful summary of whatever needs to be done. Kunal has a question for you. That you demonstrated using the Corin planner, the heat mapping is told to be useful for determining uncemented implant fixation. Does it also work for cemented or hybrid fixation? How does it work for cases with deficits, loss, protrusions, and which need impaction bone grafting?
Yep. So look, this system is about templating and orientation. So your orientation, regardless of whether you're putting in a cemented or cementless, is going to be the same. The position of stability of the acetabular component requires appropriate inclination and anteversion for the spinopelvic issues that may arise, and a decision whether you use dual mobility or whether you use a fixed bearing. So it really doesn't matter whether you're using cemented, hybrid, or cementless. The program still works. It's about overall positioning and then securing that position intraoperatively to optimize the position of stability. In terms of protrusio, you saw that case I shared with you. That's not a straightforward hip replacement. And the question here is, do we use primary implants or do I have revision gear? By using this a week ahead, I made the decision I don't need revision gear there. I can actually do a primary here because I can see the fit, and it's a three-dimensional way of optimizing the position and the fit of that acetabular component, giving you confidence to proceed. Now, in our country, we can have every implant on the shelf, but in countries that can't do that, I can see that as a definite benefit.
Yeah, so just a quick question again, Prof. The audience will be basically from very varied backgrounds, from robotic users to non-robotic users. What differently would you advise to the non-robotic users as something that you would do to get the 3D balancing of the hip correct every single time?
So what I showed is 3 versions of a software program from different companies. So no doubt this will develop and evolve, and there'll be versions in every country, maybe locally developed, that deliver the same outcome. I've got to emphasize, I don't use robotics for hip replacement. So what I demonstrated there was patient-specific instruments that can be 3D printed in your own office if you want to, and have them available and connect them to a simple laser that can be bought anywhere. So it's a much cheaper way, if you don't have access to robotics, to deliver a satisfactory outcome in terms of positioning of your acetabular component and the PSI for appropriate neck osteotomy cut.
Thanks, Prof. May I now invite our next speaker? Any questions, any comments from Simon? Are you there?
None from me. I think Rami
Okay,
has done that fine.
Yeah, sure. So maybe we can have you question in on Dr. Rajeev then.
Sure.
Yeah. So may I now invite Dr. Rajeev Sharma to deliver his talk on Dr. Rajeev, sir.
Yes.
On combined offset restoration.
Yes. Thank you, Abhay. Abhay, just 1 minute. I'm not able to share. Abhay, can you see my screen?
Yes, we can.
Thank you, Shahid. Thank you, Abhay. Thank you, Rami and David. Rami has taken a wonderful talk on the 3D balancing of the hip. And I think the 3D balancing is very important. And how to do this balancing, as Abhay has rightly asked, the people who are surgeons who are not having the access to the robotics, how to do the balancing of the hip, we'll discuss in brief here. Key surgical goal during any total hip arthroplasty is to recreate the natural biomechanics. To do that, the well-balanced offset is very, very important. And here I'll be talking about the how to do the good balancing of the offset, something which we were not doing as much in the past. So combined offset is the sum of the femoral and acetabular offset. If you see the femoral offset, that's the distance from the center of the femoral head to the center of the axis of the femur, and acetabular offset, the distance from the hip center of rotation to the medial wall of the acetabulum. The femoral offset one has to see in the horizontal as well as vertical offset. The perpendicular distance between the long axis of the femur and the center of the rotation of the hip will be the horizontal offset, and vertical offset, as we say about the leg length, it relates to the overall length and height of the leg. If you look at the biomechanics, it is so much important that unless we restore the offset, and as Rami has mentioned, the three-dimensional thinking about the balancing of the hip may not function well. Why to restore the hip dynamics? Because you need to have the preoperative planning. You need to have the templating, select the right implant components, and plan for any necessary adjustments. And also intraoperatively, when you're using the trial components, you again have to recheck how to see the things, the various parameters, and what is to be seen on a preoperative X-ray. One must evaluate the acetabulum, the femoral evaluation, the pelvic obliquity, and the leg length discrepancy. When you are assessing the acetabulum on the radiology, you see that margins and peripheral osteophytes, you see the protrusio, you have any cysts in the X-rays, you have any defect of the medial wall, or if the medial wall is very thick. And when you open up the hip joint, you will try to imagine that what the radiological findings are, and you'll match it up with the physical findings of the peroperative time. The femoral offset, you will assess the offset, you will assess the neck cut level, you'll see the canal diameter, which is the narrowest part of the canal. You see the femoral bowing, any proximal migration of the trochanter, and say, for example, in the dysplastic hips, and you will see very well about the vertical offset and the horizontal offset. The templating one can do, though in today's time of the digital X-rays, the templating has become a difficult aspect, but one must have an assessment of the position of the acetabulum, the osteophytes which are there in the patient preoperatively, the expected size of the acetabulum, and the femoral component, what position you are going to have and what size of the implant you are going to use. In my hand, the few simple ways of assessing the offset. You make a mark in the trochanteric tip, make a drill hole in this area, and yes, the drill hole in the trochanter and a drill hole in the lesser trochanter, and I put a mark on the femoral head. Here, what we are measuring is the horizontal offset. Then you are measuring the vertical offset, and you must do it before you make a neck cut. You must have a measurement. You try to match it up with the trial implants, and then you see that once the horizontal and the vertical offsets are matching well, then what you need to see is the combined anteversion. And you also have to see, make sure that the balancing of the hip joint, the soft tissue tension is correct. So once we have all these aspects measured well, so the similar thing, in every patient, if you just these simple methods, this works very well to assess the vertical and the horizontal offset. The coverage of the femoral head in the acetabulum has to be assessed, combined anteversion as we just discussed. And the soft tissue tension, here you see that you have a little bit of laxity. And in the discussion, we may discuss that how much of the laxity we should leave. And then you see that you increase the size of the femoral head, the neck size, and then you can have a better stability. So for some amount, some millimeters of the leg length discrepancy, you can assess here. The importance and benefits of the offset restoration are normalizes the hip biomechanics, enhances the implant stability, improves the long-term outcomes. And how it is normalizing the hip biomechanics, because it correcting the vertical offset prevents the leg length discrepancy, which can cause a poor posture and painful hip. And restoration of the correct horizontal offset ensures optimal tension for the abductor muscles, helps prevent the muscle fatigue and limping. The implant stability, it enhances, optimizes the offset, optimizing the offset reduces the risk of the joint dislocation by providing the proper soft tissue tension. It also minimizes the risk of the impingement. And it also helps in long-term outcomes. The proper positioning of components, especially the femoral head, reduces the wear on the implant's bearing surfaces and increasing the longevity of the hip implant. And patients with accurate offset restoration, they experience better functional outcome, improved gait, improved range of motion, and a better abductor strength. So consequences of the poor offset restoration are the instability and possibly dislocation, limb length discrepancy, and limited range of movement. Poorly restored offset can lead to impingement, and a reduced range of motion has been accepted very well. The impingement, as you see on this picture, see on the right side, the offset is not restored, and that's how you see that the abductor mechanism is not efficient here. So such a patient will have problem when he walks. The hip, even if it does not dislocate, the abductor mechanism weakness will cause him a lot of limp and for a very long time. Restoration of the offset is very, very important, as we just discussed. Some examples of the poor offset restoration, my own patients. The long back operated somewhere around 2000. The dysplastic hip, here we see that the offset is not very good, very well matched. And such a patient will have a problem. That is again a patient operated for a total femoral replacement. But even here, where we have used the constraint cup, and constraint liner, you see that what is the effect of not managing the offset, though there may be other factors also. But you see that this patient who had the offset was not matched as on the other side. You see that this patient in a short follow-up time of maybe around 5 or 7 years had a broken ring. And that's how this ring was, there was a failure of the poly because of the broken ring. And that's how this was again operated, and the stability was managed by change of the constraint liner. Another patient operated somewhere in 2004. This patient was done at that time the metal-on-metal hip implant. And you see that this patient was doing well with the ASR cup, though it was not a very good choice of that time. And you see what happened was the cup slipped. And with the cup slipping, we see that there was a major issue because the medial wall was breached. So at that time, we did not have the cages also here frequently available. So the method that we used at that time was a lot of bone graft from the iliac crest, a multi-hole cup, and I lateralized the cup and increased the neck length. And that's how I could manage this patient at that time. But in today's time, when we have all the implants available, I think it's a very, very important that we should try to restore both vertical as well as the horizontal offset for all the patients. You see, wherever you have a good restoration of the offset, you see the function of the patient. It is definitely different. And it is not just that that the offset alone is important. It is the antiversion. The combined antiversion is very important, and the right amount of the soft tissue tension is very important. And of course, the stability of the implants. One example, you see that this here we revised the proximally shattered bone with infection, but here you see that the offset of both the sides was matched. This is also a constrained implant, and this patient did very well even at a long follow-up. You see that at a 7-year follow-up, this patient is doing very well. Another example of this patient who is doing extremely well after the hip arthroplasty. Another example of an ankylosed hip bilateral. See that the restoration of the offset is very, very important in almost all the cases. Another patient, the modular stem over one-piece stem is very useful because the modular stems will give us a far better way of managing the offset in the right way. Restoration of the offset is crucial because you need to have the stabilization of the columns. You may need to have the special implants like cages, rings, and augments. One patient where the acetabular offset was managed, like in this patient where the hemiarthroplasty had almost breached the medial wall. So here we used a lot of bone graft, and because more than 60% of the wall was intact, so that's how we could get away without using a cage in this case. Another example of where the acetabular offset was disturbed severely, there was a medialized cup. The cage was used in this case, and with the use of the cage and lateralization of the cup, we could manage this patient very well. So what is very important is that the horizontal and vertical offset restoration of both is critical, and acetabular offset also should not be missed. So as much as possible, even without the technology, I'm sure that we can manage the hip in a very good way in today's time. Thank you so much.
Thank you, Dr. Rajeev.
Very much.
Yeah. Yes, Simon, please.
Thanks very much, Rajeev. That's
there are
really
some questions in the
comprehensive.
chat box also, Simon,
Yeah,
if you want to
we've got a
take one
couple of
those.
questions, Rajeev. We'll just take 2 questions, I think. I'm going to take Chairman's prerogative and ask the first question. And you mentioned the importance of acetabular offset. How do you plan around restoration of acetabular offset? It gave us a great demonstration of the femoral offset. What are your key points in acetabular offset restoration?
Simon, that's a very important thing that we have been assessing and seeing the femoral offset frequently and measuring it up. The acetabular offset assessment is slightly more tricky because you need to have a assessment preoperatively, and peroperatively you need to have in mind the preoperative assessment. The right way could be that from the measurable fixed places will be the pubic symphysis. On an X-ray, if you measure from the pubic symphysis to the acetabular cup, the medial wall, and see that how much the cup is medialized or lateralized. In certain situation, we have seen that even a lateralized cup poses a major issue because you increased more than the decreased offset. The increased offset because of the lateralized cup can be a major issue because that will cause a huge amount of tension in the hip. So I think the measurement is very easy on the preoperative pelvic X-ray, and the assessment of it and managing it on the table is equally important.
Great, thanks. And one last question, this one from Rami by the look of it. When you've got a patient who's got extreme either coxavera, coxavalga, do you vary your stem choice based on that? Do you change your stem, and if so, how?
Yeah. Simon, if you have the coxa, or if you have the deformities in the distal part of the femur, you need to have the assessment accordingly. And the stem choice is very important, and it has to be dependent upon the bony morphology, the femoral morphology. If you have a dysplastic hip, I'm sure that we'll have to have the arrangement for the small cups, is small femoral stem, all right. And also in cases where you have a say door type A femur, you need to have the right kind of the femoral stem. Say for example, in a if you have a bowing in the femur distally, or the say at the isthmus level, then you will have to have the modular stem, and that is what is the right way.
Thanks, Rajeev. In the interest of time, we'll move on, and we'll introduce Abhay with your talk. And Abhay, you're going to talk to us about taper science, what makes it relevant. Thanks, Abhay.
Can you see my screen?
We've got it, yeah.
Yeah, so am I audible?
Yes, you are.
Yes, you are.
Okay, thank you, Simon. So taper science, we have two talks on this. Mine is what makes it relevant? Why do you want to talk about it, and why is it important? So essentially, it's a story of managing fixation well on the femur and providing enough stability for the stem to osteointegrate into where you have put it, so that we have appropriate restoration of our offsets. And when you talk tapers, you are essentially talking taper mismatch at the head-neck junction, which essentially is a statement of how you will vary or avoid fretting, corrosion, and wear. So this is a bit of understanding your stem well. It is a bit of understanding that not all the 12 and 12-14 stem tapers are different. So you can't marry a head of a different company with a stem of a different company, because despite having the same tapers, the head taper and the stem taper mismatch can be different and is different, and that can lead to fretting and corrosion. And of course, there are some technical bits to this, so that you want to keep your head absolutely dry before you put your head and marry it to the stem that you have. But when we're going to talk a little more of stem geometry. So you have a patient who can have a single, double, triple, or a conical taper, and how does it matter, and does it really matter? So what we're essentially looking at dealing with is asking ourselves what will give a rigid initial stability for a good mid to long-term biologic fixation, for a successful balanced femoral stress distribution for long-term survivorship. And what we're also looking at not doing is to prevent early failure and to avoid periprosthetic fractures in our need to provide a scratch fit. And therein come in the issues of not only the tapers and the stem side geometry, but also looking at surface features and the cross-sectional properties, which are important to consider in given situations. What we're essentially trying to talk and discuss is that we need to marry our stem, the stem geometry for all types of stem, towards the quality of bone, the amount of bone defect, and where exactly are we looking to get our fixation in the femur. So if you see the proximal femur, it is a cone. As you go distally starting down the isthmus, you start to have a cylindrical femur. And if you have a bone loss extending way down, then you start to walk into a reverse cone. And obviously, one stem match all does not do the job. We have to choose horses for courses in these given situations. And that is where the tapers, the single, double, triple, and the distal fixing stems, all those come into the picture and play. So what does taper do for us? A taper wedges a stem into a femur and gives us axial and rotational stability. It allows for certain amount of controlled subsidence, which in a way enhances the stability as per the geometry of the femur. It allows for a more natural load transfer, which in a way minimizes stress shielding and thigh pain. And it addresses several complex pathologies wherein distal fixations are required, and therein we use not only the metallurgy but the geometry of the metallurgy and the additional provision of splines on the geometry and the metallurgy to provide fixation. And what we're essentially talking here is the type of taper. So you could have flat taper stems, quadrangular taper stems, fit and fill issues, conical stems, cylinders stems which have no tapers, and then short stems which Deepak is going to allude to. So the flat taper stems are essentially tapered primarily in the coronal plane. You have the taper locks, the ML tapers, trilock and accolades 2. They provide medial to lateral metaphyseal cortical engagement. The fixation is also along the length, which is a 3-point fixations, and these are broach-only stems, where so they provide a geometric mismatch to provide good torsional stability. On the other hand, there are quadrangular taper stems, where the initial rigid fixation is a little better than the type A stems because they have an enhanced fill in the metaphysis on the sagittal plane as compared to the type A stems, and they provide a little more homogeneous load transfer, and these again are broach-only stems. A word here about the very successful stem which is Corel, which has been documented to show incidences of potting, or because of the proximo-distal mismatch which happens. It is seen in the smaller sizes from 8 to 12, where we get a false distal sense of fixation and we leave the proximal stem loose, and that causes a windshield wiper effect, which is seen more in males, more in the smaller stems, and much more in the anterior approach. And therein you have subsidence of these stems and early loosening and the need for revision. The next on the business card is the fit and fill stems. So you have synergy and summit stems, which are more circumferential engagement of the metaphysis and proximal femoral cortex. These are ream and broach stems. And then the conical stems, which have 5-degree taper distally. They have longitudinal splines for axial and rotational stability. And each of these stems, Wagner, Redapt, Reclaim, they have different distal tapers varying from 2 to 3.5. And these can have monoblock and modular components, which Kunal will allude to. And these are ream-only stems. And then come your cylindrical stems, which deserve a mention because they do not have a taper. They will provide scratch fit for only 4 to 6 centimeters. And they are circular in cross section, so they provide osseointegration usually distally only, and they subside by about 0 to 3 millimeters and do not show any subsidence beyond 2 years. So they are stable stems and provide an average canal fill of 92%, and they are unstable stems which will show lesser canal fill with these particular stems. So that's the difference between tapered and cylindrical. For want of time, I will skip this. And then you have the neck preserving stems, which Deepak will allude to. The other thing that we need to consider is stem modularity, which will be covered by Kunal. It suffices here to say that the modularity can be provided at the head-neck junction, neck, subtrochanteric region, or the modular metaphyseal fixation sleeve level. So the take home for this brief would be that stems need to provide rigid initial stability, midterm biologic fixation, and a balanced femoral stress distribution. And therein comes the need to identify the kind of stem, the taper that we will use based on the geometry of the femur that we come across. And that is very important to identify because we want our stems to provide the wedge-like press fit with controlled subsidence, more natural load transfer, and in some certain situations, distal fixation. And it is also important to remember and understand the head-neck junction and the cone and a cone fixation. We need to understand that all 12-14 tapers are not similar, and that we will need to prevent fretting, corrosion, and wear in our stems. Thank you for your time.
Thanks, Abhay. That's great summary of cementless taper fixation. Tell me, are there patients that you will absolutely vary your stem choice, and if so, how many stems do you select from when you make those changes?
So to answer your second question first, so there the basic decision is essentially considering the neck shaft angle and the proximal femur anatomy. And by and large, we work with a standard fix of stems that we will use, the proximal fixing stems, and usually the proximal porous coats do very well in Doré and Bs. The only situation where we will wonder is those which we have a proximo-distal mismatch, or femurs where the proximal femur starts to show some abnormality or a varus remodeling. And those are the places where we'll start looking at alternative solutions in terms of the tapers that we will use.
Do you ever find yourself using a distal reamer for a very tight distal canal so that you can shape the femur to match your stem, or do you change the stem?
If we have the supply of and the competency of having everything on backup on the shelf, yes, you can change the stem, but it still costs more. So if I am not stuck in a very bad situation, I would just try and slightly over-ream the distal canal to fit a stem which will do the job for me, the planned one on the table.
Okay, thanks. Are there any more questions from the faculty?
Yeah, I have one question and one comment on that. Because of this geometry of the coral type of stem, which is quadricular cross section, rightly pointed by Dr. Abhay, that distal fitting and proximal loosening. Nowadays, I have started always keeping a femoral nailing system as a backup in my OT whenever I am using the coral stem. As it's always mandatory when I am using it, because more than 2 or 3 times I've already been stuck in between and I have to ream it with using the canal reamer. My question, Dr. Abhay sir, you had put a slight note on the taper signs of the proximal part. See, the 11-13 taper is no more in use nowadays. We are using 12-14 taper. And our personal experience showed that 11-13 taper has more issues with troninesis rather than other thing. And it was used to come with that cylindrical stem. Unlike that, but in the Esron type of stem, still they are doing very good despite being 11-13. So now all the literature says 12-14 is better, 12-14 is better to prevent troninesis and these subsequent complications, consequences. But still the Esron stem with 11-13 taper are doing good. Do you have any idea what is your take on that? Despite being 11-13 taper, Esron is doing good, but 11-13 taper AML is not doing good. Is there any difference in the geometry or the signs of proximal taper, sir?
So I have an idea of what you're talking and where you're coming from, and the answer, my thought process to that would be that with any kind of head taper and the proximal stem taper, there is something which they have described as a taper mismatch angle. And as long as that taper mismatch angle is within the confines of not causing any loosening or offloading the head from the stem, it will work. And that is predominantly the reason why literature across the world says that we have to use the same head for the same company's stem, because that is the perfect marriage for a particular stem. But saying that, that is probably the reason why the residual 11-13 tapers are still working and they're doing fine. And the 12-14 tapers of the newer designs, if used correctly, they will also do well. So I don't think it is as much a question of the taper today as is the certain specific misuse which led to problems with the earlier tapers.
Thank you, sir.
So we can go forward to have Kunal.
Yeah. Thank you. Excellent discussion. We have had discussion on the 3D balancing by Dr. Rami, and then followed by the offsets and now the taper signs. So let's move on to the modularity and how it affects the 3D balancing using the taper principles that Dr. Abhay has talked about. So with the natural interference fit that a trunnion and the bore combines together, we have varied degrees of taper angles. So we have talked about the taper interference fit. So the head and the neck should fit together. That is using through the taper angle mismatch. And this taper angle mismatch is what Dr. Abhay was talking about in the last question. Every manufacturer will have a different kind of taper, 1214 being the commonest, and it's called the Euro taper or the Ceramtech taper. However, even between different manufacturers or a single manufacturer, there might be some disparity. So we have to be cautious of mixing the heads and the necks of different companies. We know we have talked about the 1113 taper in the SROM stem, the 1416 taper in the AML stems, and currently each implant manufacturer utilizes a different and a unique taper. So not all 1214 tapers are equal even within a same manufacturer. So how does it affect the modularity in a total hip? They can happen at 3 different junctions. Head-neck junction is the most commonly utilized. By changing the head size and the material, we can use a particular stem for each anatomy. Varying the neck stem junction in modular femoral stems, we have independent adjustments of the version, offset, limb length pertaining to a patient's biomechanics, and the stem sleeve junction, which can be adapted to the varying bone loss and the revision scenarios. We'll be talking through all of this. So why does the modularity matter in a total hip? Because it's easy to assemble and disassemble the components in a primary or a revision scenario. We can customize the implant based on the patient biomechanics. We can adjust the limb length, offsets, soft tissue tension, and the version. And we can achieve an impingement-free range of motion, thus increasing the longevity. All the bone defects can be addressed using the modular components, and we can mix and match the components and the materials such as the metallic or the ceramic head. The stability is a self-interference fit stability, and it is very useful in a revision scenario by easier component exchange. So how is the secure fixation? It depends on the 3 factors. First is the assembly force. Once the surgeon is fixing the head onto the neck, the force with which he is tapping onto it and how clean is the surface. Second, it depends on the patient, the physiological loading, that is how heavy the patient is and how he's using the implant. And third is how accurately it's manufactured, that is the taper specifications. We have heard the 3D balancing talk by Dr. Rami, and he has eloquently discussed how modularity affects the 3D balance of the hip. The correct implant selection and orientation enables us to achieve a personalized joint reconstruction for a tailored fit. And the ultimate goal for all hip is to achieve impingement-free functional range of motion with a good prosthesis fixation for longevity. This paper is a useful read by Professor Vijay Bose, which traditionally moves from restoring a native hip center of rotation, restoring the native horizontal and vertical offsets and the trial reductions, to a presumption that a native reproduction of anatomy will not accurately restore the biomechanics. What we have to look for is cumulative length, cumulative offsets, and a combined version. So we have to look for both the femoral as well as the acetabular sides. And they have described the effective lower limb version angle. They have described 2 particular things. That is, one is a coaxial stitch for limb length restoration and how it gets affected by changing the offsets. And second is the combined version wedges. And they have eloquently described the change of the femoral head, how it changes the version and how we offset and how we can change it intra-op and how we can verify it intra-op. So this is how a cumulative length is measured. It's not just from the femoral head, whereas it is from the top of the iliac crest. The cumulative offset, like Dr. Rajeev Sharma described, it's not just the femoral offset. We have to look for the acetabular offset as well. So next time we are templating, be it a digital templating, we have to look at the cumulative length and the cumulative offsets. So talking about the femoral modularity, femoral stem modularity was developed because there were challenges with the surgical technique of a monoblock stem. In a monoblock stem, there was inability to exchange the components, be it due to wear and tear or a revision scenario. And finally, we wanted a better match for the patient's anatomy. It helped in recreating the femoral versions, leg lengths, offsets, decrease the inventory, the costs, and allows intraoperative flexibility. For reducing the surgical site incision and dissection, this is useful. And in revision scenarios, we can manage various aspects of bone loss. There are basically three types of modularity in the femoral stems, the proximal being the largest variation, which we are using day in, day out. They are modular heads, shoulders, necks, collars, and sleeves. Second is the mid-stem modularity for complex cases in which we have a stem which achieves a scratch fit in the diaphysis, and then the proximal part is built on it. And the distal modularity has failed to show clinical relevance, so we'll move on with this. A brief example of how modularity helps in a complex septic arthritic case with a high riding rigidity. We have brought down the femoral canal with using a subtrochanteric derotation osteotomy, and we have used S-ROM stem. This is a stem with a narrow diameter and a smaller medial offset for reducing the leg length. And finally, we have different modularity questions. So this paper takes you through 4 different questions. First one is a femoral head modularity a good thing or a necessary evil? Definitely, it's useful for improving the leg length equality and as well as the horizontal offsets. However, a word of caution, the metallic heads above 36 size are not to be used because of greater corrosion and debris. Is neck modularity really useful, or is it a far-stretched idea? Well, it should be the double Morse tapers should be reserved for dysplastic hips or difficult deformed femurs and should be avoided in obese individuals in more than 100 kgs. Otherwise, it will lead to reactions like the ARMD and the pseudotumors. The third question, does the metaphyseal diaphyseal modularity really required in a primary case? Well, it's more or less useful in dysplasias and in deformed proximal femurs because of increased risk of corrosion and fracture risk at the modularity junction. Example of a dysplastic hip, again managed with a subtrochanteric reduction osteotomy and a derotation done to restore the center of rotation as well as the limb lengths. Another example of skeletal dysplasia, bilaterally operated, bringing down the femurs with the subtrochanteric osteotomy. So does the modularity help in a revision case? Well, possibly so, because the distal fixation is achieved with the distal segment, and the surgical technique is the most important thing in such cases. A connection of a proximal femur component of variable geometry and a diaphyseal stem with the press fit fixation is the solution to restore the limb length, lateralization, as well as the version. A case of post-traumatic osteoarthritis of the right hip, implants were removed and a S-ROM stem was used to restore the center of rotation as well as the limb length. So what does the modularity bring with it? It is the challenge of risk of failure. So the modular designs have these following risks. We have taper fretting, we have fatigue fractures of the neck, we have local corrosion, which leads to elevated metal ions, which will lead to systemic toxicity, ALTRs. There can be dissociation of head with the stem, and a larger diameter femoral head leads to more stresses at the junctions. The long-term effects are still yet to be studied. There was an initial rise in the publications from 2016 and greater interest in the corrosion and the trunionosis, with the publications being increased from the last 1 decade. This led to the following conclusions that the factors which may relate with corrosion, there are mixed alloy component usage, insufficient taper assembly force if not assembled properly. If it is not adequately dry or wet, taper will lead to more corrosion, lower flexural rigidity of the stem and the neck junction, previous taper damage, and longer implantation periods. Higher the head components than the neck components. The head components have more taper corrosion. The inconclusive factors are the trunion-related factors and the percentage contact, trunion angle, design, and the contact area. So what does really affect the occurrence of the taper corrosion? It can be design or material related, that is the taper surface. Second, it can be surgeon related. While assembling the taper, if the surface is not clean enough, if we are using a smaller incision and it's not adequately exposed. And finally, the patient-related factors like the high BMI, inflammatory conditions, the body fluids will lead to more corrosion. Tapers which were designed for increased torsional forces do not do well with the varus bending, which is achieved with high offset stems and the large head, especially for modular necks and the revision stems. And there have been failures at that junction. The metal on metal articulations do not do well because of galvanic corrosion and loosening and excessive formation of granulation tissue and aseptic loosening. This paper elegantly describes the stability and the factors affecting the stability of these taper junctions into three basic aspects. First is the geometry of the tapers, and the second is the topography, roughness or the surface finish of the tapers, and finally, what material it is made out of, and the patient-related factors. So the most important factor for a long-term stability is the impaction force, followed by the taper geometry. If both combine together, that is the right design of the implant and the right surgical technique will lead to more functional total hip. The manufacturing of the implant is utmost important because a high quality manufacturing process reduces the taper component through neonosis. So a basic summary of how to minimize the future taper problems in the patient, do's and don'ts. We have to reduce the femoral head size. If we are using a large size, more than 36 mm, it has to be ceramic. We have to clean the surface properly. It has to be a dry, clean environment and a single strike with the hammer for engaging the head onto the neck. Newer technologies are still being explored, like the coated necks and the peak stems. Large offset with a longer neck, the longer head will lead to higher risk, and small tapers are to be avoided. Some materials like the titanium nitride coating are still being explored. We have to optimize the taper angles, finishes, and the contact biomechanics for each patient to minimize the micromotion. There are various computational modeling analysis to evaluate the design before they are released in the market. And the manufacturing has to be precise. There has to be standardization within companies to reduce the complications. So to conclude, 3D balancing of a hip enables us to achieve a personalized joint reconstruction. There has to be a balance between modularity and durability to reduce the complications of fretting, corrosion, and wear. Surgeon has a big role by the surgical technique, and the future is focusing on the design optimization, material science, and improving surgical techniques. Thank you.
Thanks, Kunal.
Great.
Yeah, Simon.
Yeah, thanks,
Yes.
Kunal. That's fantastic. How much is 4,000 newtons of impact? Have you ever measured how you impact?
I read that paper. So what they have described it, a standard hammer, which you're using the mallet, has to be, it has to come down from 15 centimeters. So a single blow for engaging the head onto the neck, but it has to be a clean environment, no blood, no fat onto the taper. Otherwise, there are chances of loosening.
Great.
There is a similar question from Prof. That technically, what is the ideal required number of impactions and the force needed per impaction to seat a head on the taper of the stem? So I think Kunal has answered that adequately. It's 4 to 14 kilonewtons, which means a single strong blow or maybe a secondary one blow. That is a surgeon-specific thing. The second blow, however, has shown not to increase give any additional stability, but that is a surgeon-to-surgeon specific variation. And most of the secondary stability, which we aim to achieve with our second, third, fourth blows, which are usually not required, come from the fact that when the patient loads on full weight bearing after the total hip, that secondary stability is achieved. And the other component of the question which Prof has asked is, does this force vary between a cobalt chrome head and a ceramic head? So technically, ceramic heads with titanium on a titanium inner sleeve have shown that certain degrees of impaction, certain different levels of blow can be needed, but there is no real quantification on how much. Would you have anything to add on that, Prof or Simon?
The only thing I would say just in general terms about tapers is I would generally try to avoid modular taper junctions in primary hip surgery because of the issues that have arisen due to metallosis, corrosion. We went through a big issue some years ago with the introduction of what were previously successful stems and then modifications. Some of the taper technology worked really well and some of it didn't. And I think broadly in primary surgery, I would rely on a monoblock stem with a modular head neck junction. And in my practice, I use a ceramic head most of the time because I want to minimize that failure mode of corrosion.
Great.
One question to Kunal. Kunal, great presentation, but a question regarding the science of the taper in revision. That is, if you use a ceramic head and you're retaining the femoral component, so you remove the femoral head and discard. At the conclusion of the revision, any recommendations of how to treat the taper with reapplying a new femoral head if you use ceramic as the primary?
So there's a classification that's described for knowing the extent of corrosion at the taper trunion junction. So we have to look at the stem taper. If it is already eroded, it's not a wise idea to retain it and put on the ceramic head. If there is no evidence of trunionosis as per the grading, then we can put on the ceramic head because ceramic on titanium, like Professor Abhay said, leads to less amount of trunionosis and fretting at that junction.
The only thing I would add is to consider the utilization of sleeve adapters, and use that as an interface to freshen up the taper for your new femoral head. Probably a good idea.
The problem is the availability of titanium sleeve in our part.
Yeah, but the recommendation is based on ideal scenario, and then, yeah.
Abhay, can I make a small?
I can.
Yeah, sure, sir.
You see, one of the tricks that I have been using for years, and I learned from Dr. Chitra Nawat, that when he puts the head on the neck, he gives it a little rotatory force, and that makes it, and then impacting it, and that makes the somehow the strength of the femoral head on the neck better. That's what is my feeling. What is the opinion, Kunal, on this?
I think so. We can.
Was it for metallic head or ceramic head?
Yeah.
Either, whether it is metallic head or the ceramic head. So that is a small rotatory movement makes it. If you feel like that you have a better fit.
So ultimately, it's the interference fit due to the very taper angle. So if this works, we can maybe publish on it. There's no published data on this technique.
Yeah.
Just a comment again about taper science in that I use a posterior approach so I can hit the head 5, 6, 7 times. It's no problem. But there are some approaches where you can't do that at all. So the super path, for instance, you put the head inside the socket, then reduce the femur onto the head. You can't actually impact it. And that's been published by a colleague of ours, Sol Karashi, to demonstrate that that is actually stable. So the science is so good at taper engagement that just by forcing the femoral component onto the head without impaction can still lock it in place. So just another thought.
So a comment on that. So as per the described literature, if there is blood fat onto the taper surface, it will not lead to good engagement, and on a long term, there'll be micromotion and fretting. So let's keep our fingers crossed.
Less than ideal.
Yeah, so great points on taper science, and I think it's time to move on to distal stem fixation by Simon. And can you share your screen, Simon?
Yeah. Great. Thanks. Have you got that there?
Yeah.
Yep.
Great. Yeah, look, maybe we should get the patients to jump around after their operation to really engage that taper. Not not really. So I'm going to talk this evening about cementless distal fixation in revision total hip. It's really just an overview of where we've come from and really where the state of the art is. So the heritage of fixation in revision surgery is that many years ago, revision stems were just longer versions of primary stems, and results were variable due to suboptimal fixation, proximal stress shielding, lack of offset, and it was quite difficult to control length because of a lack of modularity. The Wagner stem was a very interesting stem early on. It was originally a short primary stem, and it established very durable fixation principles of what we've been talking about this evening, and that is some of that taper technology in fixation. The stem was rotationally stable, both due to its fluted design, but also its taper geometry, and was able to obtain distal or diaphyseal fit independent of metaphyseal size or quality. And it was, often quite useful in those dysplastic hips where there's really significant variations in version. However, the early Wagner stems revision results were impaired because there was a real lack of trial options initially, and the stem was really delivered only in a single offset. So this is where the modern revision stems were at least conceptualized and subsequently have been improved. Probably the most versatile and used revision style stem was an extension of the original AML stem, which is a fully porous coated stem, and it was the longer versions were introduced to improve fixation of the early cementless stems. You got predictable distal diaphyseal fixation. It was a very stiff chromium cobalt alloy porous coated stem. Whilst it worked in many cases, the problems are that it sometimes required aggressive reaming. It was very much reliant on scratch fit, and scratch fit is really a surgeon feel. So it's a complex blend of surgeon feel, patient bone quality. And even if you could get good fixation, there was an incidence of proximal bone loss and stress shielding, and plenty of patients would develop thigh pain, which was thought to be due to a stiffness mismatch. But it may in fact have been windscreen wiper effect of distal fixation with no proximal fixation. So when would we consider the use of a distal fixation stem? Well, essentially when there's compromised proximal femoral bone, either due to osteolysis, periprosthetic fracture, or septic or aseptic loosening. And really, the father of distal fixation in revision is Wayne Peprosky, who proposed this classification over 20 years ago. And essentially, we're talking about the challenges of fixation in these patients where they're type 3A, 3B, and type 4 patients where there's significant compromise to the proximal femur. There are other options where we can use combined proximal and distal fixation in the type 1 and type 2 defects. So what are our distal fixation options? Well, just dealing initially in the monoblock setting, we have the option of the cylindrical, fully porous coated stems, which is the solution stem is, I guess, probably the most well-known, or the titanium fluted stem, which is essentially the Wagner style stems, which have many different versions have been brought in. And that's a monoblock, fairly simple to use, but gives you a little less capability with reconstituting the soft tissue biomechanics. Or you can use your modular stems, and modular stems do come in both the cylindrical, fully porous coated variety or the fluted titanium taper. And most companies will give you a choice of whichever you would prefer. So what about the monoblock cylindrical, fully porous coated stems? They do rely on accurate reaming and trialing. They're a cylindrical cross section, so they by their nature, they have the potential for less axial stability and therefore more subsidence risk. You'll find that most of them will include a collar to reduce the risk of that subsidence. Because they're often very straight, very bulky stems, they have a higher fracture risk. And because they're chromium cobalt, they have less physiological stiffness with the risk of proximal stress shielding. So you can get distal fixation and then proximal stress shielding, which may not be clinically problematic, but if the patient requires revision, you're really dealing with a very deficient proximal femur. And as I'll show you in a moment, that if there's significant distal fixation without proximal support, there's a risk of stem fracture. What are the results of these cylindrical porous coated stems? So this series from Charlie Eng, who was really the father of this technique and this type of stem, they reviewed over 1,000 stems between 1980 to 2010, which is remarkable. It's the single design surgeon series with excellent survivorship at 15 years. But the problems that where there were problems, there were issues of some loosening, some implant fracture, some infections, and some periprosthetic fracture. So this is about the high watermark in terms of results of this sort of a stem in revision surgery. This paper coming from the Mayo, looking at their results, again, cylindrical porous coated stems, nearly 1,000 stems over a 10-year period. Excellent clinical results, but again, risks of revision due to either aseptic loosening, stem fracture, which you can see here, which happens in patients where either it's a smaller stem, heavier patients, and higher offset, poor proximal fixation. So you've obtained distal fixation, but not a lot of proximal support. They had some infections, periprosthetic fractures, and some dislocations, as you'd expect in these high-risk patients. So in terms of just the concept of cylindrical or taper in the monoblock series, which way to go? Well, this multi-center review of 120 stems with a 6-year follow-up looked at 54 cylindrical stems and 66 taper stems. For the patients who did well, they did well, but the complication rate was significantly higher with the taper stems. So you can see the intraoperative fracture rate was 14% with the cylindrical stems and 4% for the tapers. Subsidence was greater for the cylindrical, and that reflects less axial stability. Thigh pain was higher with the cylindrical stems. And interestingly, there was better proximal bone restoration and preservation using the taper stems. So I think it's worth, the lessons learned from that paper are that if you can obtain good fixation, a taper stem probably has a safer have a lower side effect profile. And that comes then into our choices if we want to go to a modular type stems. And this is really what I believe to be the modern workhorse of revision stems, and that is a modular fluted titanium tapered stem. The taper angle is dependent on the manufacturer, somewhere between 2 and 3 degrees. That seems to be the agreed taper angle, which allows the stem to self-lock as it's impacted, and it becomes then subsidence as it subsides in a controlled way, maybe 1 millimeter, maybe 2 millimeters, it then self-locks again. So you get this optimal distal fixation, and then once you've separated the proximal and distal fixation, you can then optimize your proximal geometry, both to restore offset, get good bone contact, and restore length. So what we're really doing here with that modularity is it separates fixation from leg length and offset management. And I think if we think about it in those terms, we'll understand the benefits of that modularity process. So again, just reiterating the point that you can vary the distal fixation and separate it from proximal size and length, and you can also vary the version to reproduce a safe range of motion for the patient and hopefully reduce your risks of dislocation. So what do we see when we look at some of the results? So this paper from Poprosky. Now, these patients, there's only 58 patients, but these are the worst of the worst patients. These are 3B to type 4 bone loss patients, mean 5-year follow-up, but that's from minimum 2 to 12 years. They had excellent stem survivorship. There was about a 10% incidence of early subsidence of those stems, but they stabilized. Just because there was subsidence didn't necessarily mean they needed revision. However, because this patient subset is a complex group of patients with multifactorial reasons for revision, there's a significant complication rate. But I think you should understand that the complication rate's not necessarily due to the stem choice, it's more about the patient choice. This group of patients, this is from the Mayo, 519 aseptic revisions using the distal tapered stem, excellent survivorship, usual list of complications, but very satisfactory clinical results. So why don't we just use tapers in every modular taper in every situation? Well, the concern is the Achilles heel of the modular tapered stem is junctional failure. And there's a number of factors involved. From the patient perspective, poor proximal bone support, high BMI, high offset stems all put the patient at risk. Those with higher functional demands, but very importantly, poor engineering. So what's happened over the last 15, 20 years is that the engineers have got working harder to create better quality tapers, stronger, much better both FEA testing and bench testing, and that's translated into better clinical results. So I think we're reasonably confident that you can trust your tapers with modern implants. However, you should still try to obtain good proximal bone contact and be aware that your bigger patients may present still some risk of taper failure in the longer term. So in summary, look, monoblock stems can provide great results, but they do lack flexibility. You can't really separate proximal and distal fixation. It is a little bit more challenging to manage your leg length and offset control. There is some version variability, but a straight stem in a curved bone can offer some difficulties, and they do have a higher periprosthetic fracture rate. So modular stems offer better proximal and distal fixation options. They do offer better leg length and offset control and give you the capability for much better version control. And in my opinion, and I think modular fluted stems have become the workhorse in these complex patient groups. Thanks very much for your attention.
Thank you so much, Simon, for a very comprehensive review. There is a question for you. So what would be your recommendations to avoid prosthetic fracture or a taper junction failure in a modular stem when you already have a distally fixed stem with no proximal host bone?
Yeah, so there are those patients. So firstly, I would still go with so in terms of my distal fixation, I would still go with a taper fluted stem because that's been associated with actually proximal bone stock restoration. The second point is I would use a stem from a reputable manufacturer. Many of the each manufacturer will have a history where they've had some potential taper failures and then they've improved their engineering. So I'd really look to a more modern manufacturer. Just the modularity isn't the only cause of failure. There are the monoblock stems also that failed because of excessive loads in that distal fixation. And in that case, you've just got to get to a bigger stem. So I think that the idea is to manage your offset, manage your leg length, use a modern stem with a good track record. And I think we've got more confidence now than we did probably 10 or 15 years ago.
So on the same line, Simon, can I ask you something that, we increasingly have newer stems, especially the non-modular ones, where there is an intentional trial to either give augments proximally to those modular stems, or they are more like Cohn-Wagner situations where, with some element of coating to give better proximal fixations. Do you feel that those stems will start functioning better or as well as the modular stems, where you really need to use the modular stems as well?
Yeah, look, I don't know. I think I like the concept of separating the distal fixation from proximal geometry, because once I get distal fixation and stability, I can then play around with the modularity on trials with my definitive implant distally. And I think I get more flexibility personally by doing that rather than having to commit to a single monoblock stem, admittedly, maybe with some proximal geometric changes. It just gives me more flexibility during the case.
Great. So one last question to you, Simon, before we go to Dr. Deepak. What would be your quick surgical tips to avoid subsidence when you're doing a stem?
Yeah. Well, that's almost a question of how hard do you hit it. I think templating is a good start. You really do have to do good templating. Understanding how the stem works. It is a wedge, so you don't have to keep bashing it, but prophylactic cabling before you do your final impaction, I think, is a good maneuver to reduce the risk of a periprosthetic split. Good quality trialing, reaming line to line, and then using the recommended stem as you impact. And I think what you'll find is once you've hit that stem 5-6 times with your moderate force and it's stable, then it's stable. And then you've got that flexibility of being able to manage your proximal segment with your trials from there.
Thank you, Simon. And may I request Deepak to talk to us on short stems, please?
Is it visible, sir?
Absolutely visible, please.
Okay, sir. I come from Mumbai. Regarding the short stems in total hip arthroplasty, I'm just going to talk about definition, the rationale for use, science behind the short stems, classification and design consideration, its indications, clinical outcome and evidence, the potential challenges and controversies with future directions. There is no any clear consensus on the definition of short stem. It's confidently used that the shorter size stem is considered as a short stem. That means a shorter stem with a lesser bone contact area. Whereas Fein and Samin has defined short stem with a length which is less than twice the distance between the greater trochanter and the lesser trochanter. But for convenience, in the literature, a short stem is defined as a calcar guided stem with minimal femoral cut. But more than a length, a short stem should be as long as necessary and as short as possible to have a sufficient anchorage in the proximal femur after minimal femoral cut. That means anchorage is more important than the length. So the rationale for use, once reserved for elderly patients, the total hip arthroplasty is being more commonly used in younger and active population. There is an increasing trend in the number of total hip arthroplasty, and simultaneously, there is a decrease in the patient's age, with more than 26% being before 65 years. That means this younger population will invariably require one or more revisions in his or her lifetime. So short stem may provide the femoral side issues by facilitating better conservation of bone structure. So the science behind the short stem is bone conservation by minimizing the amount of bone removed during the initial surgery and preserving the adequate femoral bone stock during the revision surgery. That provides proximal metaphyseal fixation, physiological load transfer, thereby reducing the risk of stress shielding, and compatible with minimally invasive procedures like direct entry approach that is being repopularized these days. But remember, bone conservation and bone preservation are different things. You conserve the bone during the initial surgical procedure by removing the less amount of bone, but that should be reflected in bone preservation by maintaining this bone stock over a time, over a long period of time, especially during the revision surgery. Again, there are several classifications for the short stems, or say the stems, which you have been saying since previous presentations also. When you come to the size of stem classification given by Fein and Sim, the type 3 stems, which lies in between the greater trochanter and lesser trochanter twice length. That means that rests between the neck, greater trochanter, and proximal part of the femur, that is regarded as the short stem. That preparation may be with subcapital osteotomy or with the standard osteotomy. But the most commonly used or the most popular one is the classification given by French Society of Hip and Knee. The type 1 is the cephalic type of stem, which is basically the resurfacing or Birmingham mid-head resection. Type 2 is the isolated cervical type, which is now no more in the market, the silent hip type. Type 3 stems are the real short stems, which is mini hip, nanos, or meta. Type 4 were purely metaphyseal. Is almost disappeared from the market because of the difficulty in retracting the implant during the revision surgery, usually the revisions. And type 5 are nowadays considered as the standard stem that has been shortened, where the implantation technique remains the same as the standard stem. It's only the shortened versions of the original longer stems. And they are available in different designs, trapezoidal, rounded, threaded, or third-placed. By and large, the type 3 are being the more commonly used, that is the meta stem. And if you go for the type 4 stem, see, the type 4, according to the SFGS classification, are purely metaphyseal, but there is small extension towards the diphyseal type, which are being commonly used nowadays, like the Treperlock microplasty, Trilock actis insignia, and the other stem. The potential advantage in the literature is bone and soft tissue conservation, physiological load transfer, evidence of stress shielding, no thigh pain, facilitates the minimal invasive procedures, and preserve the bone stock for the future revision. Indication, the indications are extended with the availability of type 4 and 5 implants. The indications are being extended. Younger patients, DOR A and B type of femur, avascular necrosis is no more a contraindication for short stem, proximal femoral deformity, and retained proximal femoral hardware. And nowadays, age is not a contraindication, but a caution, provided that the bone quality is not that bad. Even the literature with the conventional short stems, which is no more in use, they had survival of 100% at 10 years. And those which are still being available, the usage is different countries. Such like Germany accounts for 10 to 4% of short stems, but in Italy it's 17%. UK 76.8%, in Australia only 2.9%. Despite this, the Registry of Prostatic Orthopedic Implants has reported that at 10 years, the survival is up to 95.7%. And at 15 to 17 years, it is up to 92 to 94%. But there are still some potential challenges that has to be cleared. It has issue of primary stability and implant migration. It has got a steep learning curve. The surgical technique is very, very important. And the risk of perifascitic fracture. But the risk of perifascitic fracture comes from surgical technique itself, because it is to do with the patient selection, patient bone anatomy, and the proper technique. So are the theoretical advantages of short stem real or not? They are, yes, real. Because the myths has to be solved. The proximal cut using the short stem incurs a risk of intraoperative fracture, but the literature is that there is no greater or maybe even lower than the standard stem. Yes, there is a risk of stem migration, but not more than 5 millimeters. This kind of subsidence in a short stem does not continue over the time, but is rather an early readaptation of the stem after metaphyseal cancellous bone compaction. And many of the time it is talked about extraction of the short stem causes more bone loss. It is because with the type 4 stems, it incurs problem and GT fracture, which is no more available. And for type 2 and type, it has no such difficulty during the revision surgery as well. So what is needed is the learning of for proper implantation. One, proper planning. You see whether the neck is varus or valgus. Short stems are usually good suitable for a valgus stems. You need to template it properly, and you see the entry. It's not at the conventional stem. It follows the calcar and not the mechanical axis of the femur. Neck cut, preserve 5 millimeter to 1 centimeter of the lateral cortex. You can always recut, but you should need at least 5 millimeter of the lateral cortex for method type of stem. Remember, your first broach determines the position of the rasp. The rasp works on the calcar and the position themselves orthopedically to the neck anteversion. You cannot change the anteversion then after. The rasp opens the cancellous bone of the neck and locates the lateral femoral context, where support is essential for the third step. The third fixation is in the lateral cortex. So what we usually do after opening up the canal, used to pass up the bone lever or the suction tip to feel the lateral cortex, whether it is filling the lateral cortex or not. Remember, fixation is metaphyseal. The purely diaphyseal fixation should be avoided to prevent subsidence in future. A standard neck is always preferable because if you have a short neck, it will cause a cam effect between the neck and the cup. And the final implantation is around the corner concept, where the stem itself takes the position guided by the physical curvature of the calcar. However, remember, the patient needs to be informed that it may be necessary, it may not be necessary for all. If you feel that the primary stability or the lateral cortex or the medial calcar support is not good, you may have to change for the conventional stem or the standard stem. That's why whenever you used to do meta stem, a bicontact stem from the same manufacturer will always be on the backup. Come about the bone conservation. See a patient 10 years down the line, he had a trauma, not bad, he had a fracture, neck failure. It could have been revised with again a short stem. That means the short stem revised with just short stem for 5 years. Another patient who sustained road traffic accident and acetabular fracture at the age of 22 years, open reduction, internal fixation done elsewhere, developed secondary arthritis, underwent ASR at the age of 25 years. After 3 years, he underwent totally arthroplasty with ASR. And at the age of 40 years, after 15 years after the surgery, there was some issues in his right hip, pain, and the rise in the blood metal levels, which was still revised with the help of the short stem, with both femoral and the acetabular component being revised, and that is 4 years down the line. For our experience, we have been using the short stem in all the patients where it is indicated. That means young patients with good bone stock who don't mind using the short stems. Particularly this case, proximal femoral deformity. I think such type of case, similar case, it would have been gone better with the short stem, where you can negotiate the short femoral stem in the proximal femoral. Another case where you have an obliterated medullary cavity with previous hardware. If you have a sufficient area for the proximal, in the proximal femoral area, you can go with this short stem. Also, in case of post-traumatic, avian, removal of the screw, if you have a sufficient lateral neck and the medial calcar, still go for a short neck. Similarly, if you want to preserve the proximal femoral bone structure with retained hardware, you can cut off the the part of the implant that is coming on the way of implantation and go along with the short stem. Another case, we have published our series of using performing totally arthroplasty in acute acetabular fracture Young patients received short stems irrespective of the type of acetabular fracture. The femoral side, they received the short stem. Used in tubercular arthritis as well, use of short stem. In fact, we have given the choice of stem in case of tubercular arthritis in our paper, saying that if the patient is young and the bone stock is good, it can still go with the short stem. Even in the case of protegio, if the acetabular reconstruction can be done with impaction bone grafting, the femoral side bone stock is good, you can go with the short stem. We have even published our series of use of short stem in totally arthroplasty, encouraging the spondylosis as well, where the bone stock is good. So to summarize, it preserves the proximal femoral bone stock, decreases stress shielding, decreases the thigh pain rate, facilitates minimally invasive surgical procedures, facilitates surgical procedure during the revision, and the increasing indications with modern design, especially type 4 and 5 stems. So do you think that the short stems, which is not being available in India, it is going to go on? The future, it's not like that. I think the short stem is going to stay there. People are moving from short to stemless designs. I think with better osteoconductive coatings, it may have good results in the long term. And people are making the 3D implants to adjust the proximal femur anatomy in case of dysplastic femur vessels. And for me, where I do a lot of direct entry approach, short stem is a boon for me, because in a short stem, especially with the medial entry, you do not necessarily always have to elevate the proximal femur up. Even with the femur not being sufficiently elevated up in a medial entry, if you have a good trajectory path, you can safely go with the short stem. So even the literature says that standard stem claims showed more complications and significantly more intraoperative fracture as compared to the short stems in direct entry approach. So we have also published our result of 200 patients, where 30 patients underwent totally arthroplasty direct entry approach using the short stems. But unfortunately, the short stems, the meta stem, has been withdrawn from the Indian market. This particular patients, the right-sided younger patients, young patient, autodiabetic profession, had a traumatic fracture neck of femur, underwent totally arthroplasty by direct entry approach using the short stem. When he came back again after 4 years, having after 6 years, same fracture leg, fracture neck of femur. That time I had not this short stem available, and I went for the type 4 stem, that is the mini TR stem from the Merit. Thank you for your kind attention.
Thank you so much, Deepak. And there is a question for you. Dr. Avtar wants to ask you, have you had perforations, and when you did, what did you do?
Yes, sir. Yes. Medial perforation, yes, I had a couple of times, but the best part is, even if you have medial perforation, you can readjust it. And if you have a good fixation primarily, you can go along with it. Lateral perforation, once I had it, it was missed during the surgery. In the post-operative period, I had an X-ray there. I had seen, if someone had seen it, it was missed during the primary surgery. I kept it and follow-up. The patient did well after 2 years, and after that, he lost for follow-up because I shifted to Mumbai. I did have to revise. And 3 cases, we had to revise to the standard step. It was in the initial learning phase of a short stem, not in the lateral phase, sir. Yes, I had perforations.
And another question for you, Deepak, is that what is your experience of using short stems in AVN situations?
Yes, initially it was said that the AVN sometimes extends up to the neck edema, but the literature is not, contraindicating to use the. We have sufficiently used short stems in AVN. In fact, one of the articles recently published by Vikrant and Dr. Malhotra in Clinical Orthopedic Surgery, they have explained it well. Use of short stems in AVN as well. There is no contraindication today to use short stem in AVN.
Okay, great. And just Simon, can I bring you into a question from a very proficient arthroplasty surgeon from the Asia Pacific? Dr. Kelvin wants to ask you, these kind of fluted stems that you talked of rely on a good isthmic fit. In cases where the isthmus is also deficient or fractured, what would be your tips to improve reliability of fixation in these situations?
So, yeah, thanks for the question. There are limits to fixation. The limits are explored by the diameter of the canal. If the canal is can handle that. I think 22 is the biggest stem, then you can use that. But there's always a limit to what can be done. But you can do it when there's a poor isthmus. The reason for that is that the taper helps you out. Which is different to when you're using a cylindrical stem which doesn't have the taper. So the capability of the conical, the tapered stem is greater than the cylindrical stem, but there will be a limit. Your templating helps you, and your other options then are, they're limited, but there are a number of different techniques like intersusception techniques, allografts, those sorts of things. But that's really getting to the end of the scale. And then, of course, impaction bone grafting, which I know David's going to talk about. So we'll be interested to hear what David Choon's thoughts are on that.
David, you want me to share your screen with you?
Can I share one brief comment?
Yes, sir.
Yeah. Deepak,
Yes.
in your case that you have shown for fracture neck of the femur after the BHR, and this has been because we all have used plenty of BHRs in past. The one good trick in this management of these patients is where you have a good fixation of the cup, which normally is BHR cup has a very strong fixation, which may not fail even after 10, 15, 20 years. The one good way is that just take off the femoral side and use the dual mobility liner and use the BHR cup as the dual mobility cup, and that saves us the patient a lot of trauma of revising the cup, and it works very well. Yeah, so that may be useful for all. Yeah.
Right, sir.
Thank you. Thank you, Abhay.
So I have another question for Deepak, but we'll reserve that. Dr. Avtar has asked that, but for after in the question answer session. So sharing David's talk on impaction bone grafting.
I'm not sure if there's audio on this. Abhay, is there any audio? You're muted.
Yeah, I can hear the audio. Can everybody else in the faculty hear it?
Yeah, very well.
Yeah. Okay.
No, we can't hear it.
Oh, but there is. I can hear the audio. Would you like to speak on the
I'm fine with that.
Yeah. Okay. Please go ahead. The talk is playing. Do you want me to take it back?
Well, actually, it's just to say that I was introduced to this by the Exeter group, and the Robin Ling and Graham Gay and John Timberlake came around in the 90s and taught us how to do this. Can you just run the slide? So run the show.
It's a recorded slide.
Yeah, I know.
It has
Just
a
run it.
voiceover. Yeah.
Yeah. Is it running? Okay.
Yeah.
Well, okay. Well, the thing is that if you have something that's successful, it must be replicated worldwide by all kinds of surgeons on all patients. And this is a study that actually comes from Sweden, where they actually looked at a large number of patients with excellent results over 16 years. You got like 99.5% survivorship on that. It should actually be running, but it's not. I know because it's faster than this. Is it actually running?
Sir, the audio is not coming. Is it for me only or?
Yeah. So the audio is not coming now. Can you just speak on it, David?
Yeah, no, I'm quite happy to speak on it, but you just
Yeah.
let me. Your people have to technically override this. And so anyway, this is another paper from Japan. Hiroshi Fujita, my good friend, did this, and their follow-up is much shorter and also very good results. This is the original study from Sloof et al. Also excellent results. 94.9 total overall survivorship and 99% at 10 years, which is their follow-up period. Lots of surgeons, lots of patients, and excellent results. This is the original series also from the Exeter group. They, of course, used to handle all the revisions from all over UK, and that's 705 cases over a period of about 10 or so years. And again, at 20 years, the survivorship was 99%. And that was pretty good. What do you need? Actually, not a lot, it turns out. Basically, you need a fridge, but you don't need just a simple fridge. You need a pretty good one that goes to minus 85 degrees Celsius. I started the bone bank at University of Malaya in the 1990s with the Reachers grant. We enlisted the aid of Prof. Aziz Nader to help us. His bone bank preceded ours, but you know, Singaporeans have now advanced beyond bone grafting, so nobody uses the bank and it's gone into oblivion. Ours, however, is still going very well today, and we supply bone to the whole of Malaysia. I don't know what's happening, but it should be running. Okay, what can you do? Turns out you can do quite a lot. Okay, we've done lots of cases with impaction grafting, and we have publications from this. But I think just to illustrate to you what is entirely possible, I will just show you one of the most amazing cases that we did about 15 years ago. This is a patient who just turned up at University of Malaya from a northern state. And you can see from his x-ray that he's got a lot of loosening of both sides of the implant. The cup is loose, the femur is loose, and it's sticking out of the bone. There's a huge amount of bone loss. And even if you wanted to use a cemented implant for this, you'd have some trouble trying to get one to fit in well. So we're going to show you soon a video of what happened during surgery. And I'm not sure why it's not running because I know it runs faster than this. So basically what we did was we did an extended anterolateral approach, which is my standard approach for all these things. And we completely denuded the proximal femur, and we performed impaction grafting on it. As you all know, impaction grafting is where you use morselized allograft bone, and you impact it into position using a tamp like this one here. It's called a phantom, and I'll tell you, even the company themselves in Malaysia, if you ask the reps what a phantom is, they actually have no idea. It's so much in the museum. I probably myself belong in a museum. But once you do it this way, you get such good between the graft and the bone that your implant stays stable from day one. So here is that case that we did. We reconstructed the entire proximal femur around a K-nail, completely denuded bone and applied this mesh, and then we impaction grafted into it. That is just with the trial, and it's absolutely stable because we used a lot of force to hold it in place. So it's really running slow. So, okay, that's the immediate post-op film, 2009. And you can see that it's a very extensive amount of metal mesh we've applied to it, and there's probably not much extramedullary bone supplied to the proximal bone. He stayed in hospital for 3 weeks. Then we sent him home, and we didn't hear from him for a year, whereupon I sent a search party for him. And it turns out he had been involved in a road traffic accident 5 months post-op. His bicycle had been knocked over by a car. He fell on the road, but the implant remained intact. And I'm going to show you soon, I hope, the post-op X-ray, which is here. You can see that there's excellent bone incorporation. That implant is as stable as it's ever going to be, and it's never given us any more trouble since 2010. So I would put it to you that impaction grafting works in many hands all over the world if you are willing to invest in a fridge and a technician. It's a lost art. It really needs to be restored because it actually saves a lot of costs for all of us. And in some countries, it may be problematic, such as in Pakistan, where people have to be buried whole. But in countries such as mine, where there's a certain number of Buddhists who are the most generous with their body parts, it actually works very well. Thank you very much.
Yeah, so we are done with the talks, and may I request Simon and Mr. Noor sir to go on to the case discussion panel, and we can take any further questions that come up there itself.
Thanks, Abhay. Shahid, you got some cases.
Yes, thank you very much, Abhay and Rami, for excellent presentation on different aspects. I'm going to quickly go through a few cases and pose the question to the available faculty and participant if they have question. So this is a 50 years old female, has got a dysplastic hip, and because this webinar is concentrating more on the femoral side, I would like one of the faculty who is available to comment on the anatomy of the femur and which implant are you going to use for the femoral reconstruction. Rami, are you there?
I mean, you're the man who spoke about reconstruction of restoration of biomechanics, so we'll let you lead off.
So as with everything, Shahid, I'd take a thorough history with this lady because I'd want to know exactly whether she had any surgical procedures prior to her presentation at the age of 50, how she's been managed in the past. You know, her acetabular side seems reasonable anatomy. If I was concerned, I'd certainly get a CT scan as part of the workup.
Yeah.
The femur looks quite abnormal compared to her contralateral side. It looks like something, you know, I'd be questioning whether she had some surgical procedure there in the past, but in the absence of that, I
No
can
surgical
see,
procedure in the past.
right, I can see at least on the AP that I've got a reasonable intramedullary canal to work with here. It is smaller and hypoplastic compared to the contralateral side. There's certainly pelvic tilt. There's a hypoplastic ilium and hemipelvis on that side. There's an associated scoliosis. So we've got a leg length discrepancy that has to be measured. There's certainly a different offset to the contralateral side that's got to be taken into account. In terms of workup, I'd use my software program, but I'd also use a CT as part of the workup just to identify patient's anatomy. I'd want to see a lateral projection as well. So that's all part of preparing myself for surgery. The sort of implants I'd be using, I'd certainly, in a 50-year-old, have my standard implants on hand to see if I can use them. I can't see anything in the particular film you're showing me to say that I couldn't use a standard hemispherical acetabular component, possibly with 1 or 2 screws if needed. There's nothing to suggest I can't use the smaller size of my femoral component, but I'd be very concerned about the femoral version here. So that's why the CT will help in identifying if you've got abnormal version, because then you might have something like an ESROM on standby where you can dial in the correct version to ensure that the overall combined version is correct for this patient. So that's some of the thought processes based on only one X-ray that I'd be going through in preparation.
Thank you very much, Rami, for elaborating and preoperative discussion and planning. So we had the similar thing that compared to the right femur, this is a narrow canal, this is a draw type A, and we're concerned about the version. So we had different options available. And the size and the modularity were the concern. In this particular patient, we use a non-modular corral type of implant. It's a size 6 implant. We use a hemispherical cup. These are the AP and a lateral view, and this is 6 years post-op. These acetabulum and the femoral component, the leg length is stored. She's functional. She's happy. Any comment on the post-operative X-rays, Rami?
Height, fit. Obviously, you've got 6-year follow-up, so the result is great. She's a happy patient. And her pelvis is also restored in terms of its obliquity, as you can see there. That's a good thing. So in terms of leg length, you've restored it. My only obvious comment is femoral offset restoration as compared to the other side. I mean, she was dysplastic. She's been 50 years contracted, but nevertheless, it looks like offset's not quite there. I'd be concerned about impingement between the trochanter and the ilium in abduction and maybe in extension. So they're just things going through my mind. But again, it's just based on that one film. But you've got a good outcome for the patient.
Fine. For the participant, I mean, there are always more than one way of dealing with a problem. And it depends on your experience, availability of implant, affordability. In many countries, including Pakistan, you don't have the luxury of uh, modular neck. So controlling the offset might require a varus stem, but that's the... So we shift to another case, dysplastic hip. We don't have many primary OA of the hip, and we come across many dysplastic hip. And this particular case, 54 years old female dysplastic hip, I will come to David. David, you have a vast experience of using cemented uh, total hip replacement. What are your take on for this dysplastic hip construction using a cemented implant?
Actually, so it's a standard day at the office for me. It's not a problem at all. I just see this every day almost.
Yes.
Every week. Just a standard cemented both sides.
Cemented on.
You have to know how deep to ream to medialize it. You need to have the shorter stems that we created for Asian patients because the metaphysis narrows down far more proximally, and the isthmus starts very proximally. So you're going to have this problem, particularly in male patients, where that happens, and then you need to have very large offset. That becomes much more of a problem, but usually actually been the problem for me.
So David very nicely said, but in the dysplastic acetabular component using a cemented acetabular component, what would be your strategy of dealing with the proximal bone loss?
Actually, usually if you medialize it enough, it will cover itself. It's not a big deal. Sometimes you have an issue with the actual original socket being very small because of dysplasia, and then you have to reconstruct it with impaction grafting and a mesh. You know, when I first started, I did a lot of that, but I think with experience, I've actually had to do less and less of that.
Fine, thank you. So in this particular patient, we use autogenous head. And as rightly said by David, we medialize and we put a cemented cup. And this is a C-type stem femoral component. And there's a lot of literature on these autogenous head might dissolve, but we have 8 years follow-up of same patient, and the superior augment, the autogenous bone graft is still there, the cup is well fixed, and the cemented femoral component. So we should not, it's a cementing implant is a dying skill, especially in the revision cases. And we need, as a group, to promote cementing technique. Let's quickly go to another case, and we see a lot of cases of failed fracture fixation failure. And Kunal, can I have an opinion from you on this particular case that we need to do it right first time? And failure of proximal femur fracture fixation,
Yeah.
it is very challenging for elderly patient. how would you go about in fixation on the femoral side in an elderly patient?
So this is a failed osteosynthesis intertrochanteric fracture which has not been reduced well, and the DHS has failed, and there is a loss of the abductor mechanism also. The GT is escaped. This would need definitely removal of the implants and a distal fitting stem. So I would like to go further down beyond the screws for fixation of the stem. And there are high chances of dislocations in females with post-traumatic. So I'd like to have a dual mobility cup on the acetabular side. To capture the GT fragment, I might use a plate on top of it as a hook plate for fixing the GT and capturing the abductor mechanism along with it.
Rightly said. I mean, these are the concern, dislocation, fixation, and whether a diphysial fixation or a proximal fixation, we had both options available. In this particular patient, we use a metaphysial sleeve SROM, and for prevention of dislocation, we use a dual mobility, and we restored the greater trochanter and abductor mechanism using a fiber wire. And this is 2 years down the line, and she's doing pretty good. For these osteoporotic patient, we use teriparatide, and you can see the proximal bone formation. So she's pretty happy, no pain, mobilizing full weight bearing, no dislocation. The greater trochanter is restored, the abductor mechanism is restored. And thank you very much, Kunal.
How long do you keep the teriparatide going, Shahid?
Yeah. Actually, in my experience, the teriparatide work very well in the metaphysial bone, and the result comes in 2 months, 2 to 3 months. They don't work very well on the diaphysial, but proximal metaphysial, and especially in total knee with the stress fracture, teriparatide works wonder. And in these metaphysial IT fracture, they do very well. So another patient with
question to expand on in that trochanteric fragment, large trochanteric fragment, what Kunal identified, the need to put a plate fixation hook plate. I would have done the same. So I think for the sake of explaining a little bit more your technique, because you achieved an excellent result without any fixation. So special tips on technique of repairing that using fiber wire.
Yeah. You can use a wiring, a tension band wiring. So you take the fiber wire from the greater trochanter, loop it around the medial side, and you do multiple and on table fixations. Check the stability in different direction. I have used greater trochanter grip plate, the one grip plate from French company Evolutus can have this greater trochanter grip plate fixed on the stem, and the other will have the cables available.
Great result.
So hemiarthroplasty for neck of femur and getting infected, so it's become a challenge. Simon, you'll take it.
Yeah,
Patient with infected.
Okay.
Hemiarthroplasty.
Yeah, thanks. So the first thing you'd like to know is what's the organism. So before if she's well enough, then I would organize an aspiration of the hip to try and identify what the organism is.
So organism is a simple MSSA sensitive to many antibiotic.
All right, great. So we've got what's her metabolic control? Is she diabetic? Is she healthy? Is she unhealthy?
She's healthy. She's a healthy horse. It's a moderately controlled diabetes. ESR and CRP are high. Her hemoglobin and protein and albumin level are good.
Okay, great. And was the implant functioning well before the infection, or was there pain? Because if there was pain before the development of infection, I'm suspicious of loosening. but I'm not guaranteeing that there is loosening, and that's relevant because it can be difficult to remove these stems if they're not loose.
Yeah. So she had symptom prior to this onset of infection, and we can see at the X-ray there's no calcar.
She's short. Yeah, that's right. So you can see that there's been some subsidence. So the good thing is that she hasn't got acetabular erosion, and the femoral head is not entrapped. So that's one good thing. But she's got subsidence of the stem, and it certainly doesn't look like there's secondary fixation. So she's got an infection. We've identified the organism. The question really is whether you would like to do a single or a two-stage exchange. I think the option for this is the sort of patient who would be suitable for a single stage exchange because she's biologically well. She's got a known organism which is sensitive to antibiotics which are available. So I would consider a revision where we do a single stage exchange using cementless fixation on the acetabulum. And in this case, I'd actually consider cemented fixation because it allows some antibiotic delivery, but could also use cementless fixation. And, I think she's likely to get a good result. Question of how long do you continue antibiotics? There's a lot of conjecture on that, but I would probably continue oral antibiotics for 6 weeks after the surgery.
Some in the endo clinic has got a vast experience of doing single stage reimplantation, and they rely on aggressive debridement, but they also rely on antibiotic in the cement as guided by the infectious disease person. We in Pakistan rely more on two-stage revision for various reasons. I'm not going to indulge in this, but we removed the implant, did a debridement, took multiple culture, made a spacer. Now she's 6 weeks down the line and clinically improve, inflammatory marker improve. Would you still going to continue with your uncemented fixation plan, cemented fixation, or especially on the femoral side?
So if I've decided to do a secondary, a two-stage, and I've established that the patient is now settled and well, I'm quite comfortable doing a cementless revision in that setting.
Good. So we use uncemented dual mobility on the acetabular side, and on the femur side, because of the calcar loss, we use S-ROM type of implant, mobilized full weight bearing, and she's doing pretty good.
Yep, that's a good case.
So cemented Charnley type of implant being implanted correctly lasts for many years and aseptic loosening. Abhay, can I come to you, please?
Yeah, sure, sir.
So it is not infected. You can see subsidence and there are loosening. Patient is symptomatic 10 years down the line. How would you proceed? Forget on, obviously acetabulum might need revision as well, but what are your take on femoral side revision, removal of cement, and fixation strategy?
Okay, so definitely, sir, femoral acetabulum side revision would be a consideration, especially because it's monoblock, especially because there's where the head is going slightly proximally in the socket. But on the femur side, 60 years versus 80 years, if I had this patient at 80, I would be tempted to do a cement and cement. If I have her at 60, then considering the end of tip, once the stem is in slight varus and there is some ballooning at the distal part of the stem, so I would take the stem off, do an ETO, try and take off the cement and do a distal fixing stem, and obviously do a cup revision as well.
Thank you, Abhay, very rightly said. So we need to have a planning. So we remove the implant, we remove the cement, and we had to remove the distal cement without doing osteotomy under vision, remove the cup. We use a tapered fluted, as been mentioned by Simon, that this is the workhouse of most revision, diaphyseal fixation taper fluted stem. The proximal part is HA coated, and it allows soft tissue balancing, offset setting. We use ceramic head, ceramic on crosslink fixation. These are post-operative X-rays, and he's 10 years down the line and doing pretty good.
That's a good case.
Very good. Dr. Noor, the
Yes.
cement was very loose there because
Sorry?
the cement was loose.
Cement was a big fragment of proximal cement was loose. The distal cement we had to remove, and you can so yes, the proximal cement was.
So maybe we can have this as the last but one or the last case, sir, and then summarize after
This will be the last case.
Sure, sir.
So 72 years old male patient, 1998, had a primary total hip revision, a primary total hip arthroplasty, cemented. First revision in 2009, and by 2020, he presented something like this, 3B on the acetabular side and on the femur as well, 3B. Deepak, can you take and so it's non-infected, especially on the femur side, 3B bone loss. How do you take on this?
It's a very interesting case. In fact, very interesting. I think I was thinking that Dr. David Choon would take on this case. This needs definitely revision. The curb side, you can see there is, I think, tronion head disengagement as well, right?
Yes.
If I'm not wrong.
So it's a 9-10 taper Charnley long stem and a cage. And so
my plan will be to rule out infection.
Infection is ruled out, aspiration is negative, CRP and ESR within no, not very high.
So seeing inside, I would like to go inside, take out the acetabular side. Reconstruction, I would be very good at having the impaction bone grafting and plus minus if requirement of augments in the superior part with a multi-wall cup. And the femoral side, if the cement column is okay after removal of the stem, my interest would be towards the cement and cement. But if it requires, the height will be removed all and go for a further longer stem for distal fixation.
Thank you.
Shahid, can I ask you?
Yes.
Do you have the earlier X-rays of the patient? Like you need to assess whether the cage has moved medially over the years, or it is the same position?
It has moved. It has moved medially as well as superiorly. We have a CT scan on this, and there's a column loss on the posterior side. So it's 3B, almost pelvic discontinuity.
Yes, it is. And there is a lot of significant bone loss on the acetabular side.
You're absolutely right.
So probably this will need a cage for sure, and also some bone graft on the medial side, so that there is some amount of medial bone is formed, maybe in time to come. But a cage is very important in this situation, and also the fixation in the ischium and the pubis.
Agree.
Because without that, this will not be managed for a long time.
Rajeev, I totally agree with you. So we need, when we do a primary total hip replacement, get it right first time. When we do a revision, the rate of failure of revision total hip arthroplasty are much higher compared to primary. So your fixation, there has to be a mechanical and biological fixation. So we discussed this and we opted for a custom tri-flange cup. Impaction bone grafting. So there's an ilial wing, there's an ischial wing, and also you can see that there is a bar going into the sciatic buttress. So it's a porous coated bar. So this provide a pillar for fixation. So we have a sciatic buttress pillar. We have a ilial wing, which has got a trabecular metal surface. We have got ischial wing, and we have put a dual mobility press fit type of implant. And reconstruction on the femoral side, because of 3B, we've used a proximal femur replacement. This patient is 5 years down the line, and you can see, especially on the medial side, there is a biological bone growth. So impaction bone grafting, mechanical fixation, biological restoration, both on the femur and acetabular side, and patient is pretty happy.
Great case, sir. If the questions, if the panel has any questions, and I can see no more questions on the chat box, I think we've had a great first webinar, and I think I would request any comments or quick take-homes by the panel, very quick ones, one-liners. And then maybe Simon and Prof to kind of wrap this thing up, and I'll do the Thanksgiving. Any quick comments?
Quick comment, advanced planning is the way to go. So please consider three-dimensional planning moving into the future. Just takes you one step further from what we're currently doing.
Great. Dr. Rajeev, any quick comments? One comment max to any take-homes for the audience.
For any revision, make sure that the infection remains in the back of your mind and the suitable cultures are sent and followed up. And cultures to be done at least for a period of 2 weeks. I think that is the most important thing in any revision that we are taking ahead.
Great. And Simon, anything from you? Very quick, one, maximum 2 comments.
One-liner is, when you do one operation, minimize the failure mode.
Great. Professor Shahid, sir, David, quick comments, one line, one comment.
One comment. Cement is forgiving and very friendly to everyone.
Great. Consider cemented joints.
Revision is an entirely different game. Do planning. And the rate of revision are very high in revision surgery. So do planning, and you need to have a mechanical fixation. You need to have a biological restoration. The mode of failure are dislocation and failure of fixation. So you need to involve strategies to prevent failure of fixation, and you need to have a strategy of failure of dislocation. Thank you.
And Deepak, quick word.
So
short stem specifically.
Going to come back. The short stem is going to come back.
Great. Perfect. Kunal, anything from you? One quick comment, please.
Modularity is useful on the femoral side, but be cautious of the taper junctions as well as fretting corrosions, which can happen and increase revision rates.
Great point. And my take on these stems would be to know what you're going to put into your femur, and basically to understand what is the type of defect the femur is presenting itself with, and that is the key to success. So thank you very much to all faculty. You are all giants across the Asia Pacific, and to a lot of very experienced surgeons in the audience. Thank you very much for sparing your time to join this. It has been a pleasure to introduce this particular webinar, and absolute gratitude to Simon and Prof for consenting to do this, and for David to accepting to put this on the website. So a logistic statement would be that this webinar would go on to the website by day after tomorrow, definitely, and it would be available and open towards for any questions that the delegates may have. They can access the website, put up their questions, and the faculty will answer them for about a week. And then it would stay as a reference model on the APAS website. So thank you very much for being a part of this. And a quick finishing comment from Prof before we wind up and say thank you very much.
Just that this was a great first webinar to start off and to kick things off. Abhay, very grateful for your time in organising this, and to the extended faculty here who've contributed their time. Most appreciated from the Asia Pacific Arthroplasty Society. Thanks, Abhay.
Thank you so much, Prof. And I think we can all disperse and leave. Thank you so much, everyone, to the delegates and to the faculty for sparing your time. Have a great weekend. Thank you.